Okay, hello and welcome everyone to today's webinar, The Evolution of Spine Surgery. This webinar is hosted by Medical and Life Care Consulting Services, a case management and nurse consulting firm headquartered in Massachusetts. We're excited that you've joined us for this presentation. My name is Amanda Barnett and I will be the moderator for today's webinar. This webinar is anticipated to be about 50 minutes with an additional 10 minutes provided for questions and answers at the end. Participant audio will be on mute throughout the webinar, and we ask that questions are submitted using the question and answer feature within the Zoom webinar dashboard. Post-webinar, we will share a QR code where you can access a presentation evaluation form. If you are seeking a CEU credit along with your certificate of completion, please take a moment to complete this form if applicable. We're excited to host today's webinar and look forward to an opportunity to partner with you. To kick us off, I'd like to introduce our host, Cynthia Bourbeau. Cynthia Bourbeau is president and founder of Medical and Life Care Consulting Services, a registered nurse, a certified rehabilitation nurse, a certified case manager, certified nurse life care planner, legal nurse consultant, and a certified health professional life care planner. She has worked as a nursing professional for over 40 years and currently leads Medical and Life Care Consulting Services, a practice of professional nurse consultants and case managers who provide medical case management, medical legal services, including life care planning and ancillary professional nurse consulting services, as well as vocational expert witness services and case management. Cynthia founded Medical and Life Care Consulting Services in 2001 and is presently a member of the American Association of Nurse Life Care Planners and is a board member on the Universal Life Care Planner Certification Board. She is also an active member of the Association of Rehabilitation Nurses, the International Association of Rehab Partners, and the Case Management Society of America. At this time, I'll pass it to Cynthia Bourbeau.
Hi, everyone. Thanks, Amanda. Thank you all for joining us today. I know how hard it is to take a few minutes out of the middle of your day, so thank you. First, I'd like to share a little bit about the Injury Insight program. So Injury Insight's a 4-part webinar series, and it's designated to educate professionals, claims professionals, human resource professionals, and case managers on the rehabilitation and recovery process of injuries, illnesses, diagnoses, and treatments, both common and uncommon, within workers' compensation. This program allows claims professionals and industry stakeholders to have direct access to medical specialists to help you better understand the diagnoses, the road to recovery, care pathways, and the potential obstacles, and answer your toughest of questions. So, as always, get your questions ready at the end of this talk. Now, for this year's second Injury Insight session, The Evolution of Spine Surgery, we're pleased to have Dr. Menkowitz and Dr. Paragioudakis, if I'm saying that correctly. I have to say, I recently met and learned about this practice when I was working up in New Jersey rather, and I was very impressed with the services that they offer and the expertise that they offered, and thought that they would be great to provide us some information on how things are done in New Jersey. Some of you may not know, but we are presently doing work at life care planning in New Jersey, but we also are looking to expand case management to that area and work with injured workers and injured family members. So let me introduce these gentlemen to you. Dr. Marc Menkowitz is a board-certified orthopedic spine surgeon specializing in the comprehensive surgical and non-surgical treatment of spinal disorders. He completed his medical degree at Temple University School of Medicine, followed by an orthopedic surgery residency at Monmouth Medical Center. Dr. Menkowitz then pursued advanced fellowship training at the Spine Institute of New York at Beth Israel Medical Center. Since 2008, Dr. Menkowitz has been in practice at the Center for the Functional Restoration of the Spine in Shrewsbury, New Jersey. He is licensed to practice medicine in both New Jersey and New York and maintains active hospital privileges at Monmouth Medical Center, Riverview Medical Center, and the Surgical Institute of Neptune. Dr. Menkowitz has authored and co-authored multiple peer-reviewed publications and has presented nationally and internationally on spine surgery outcomes, biomechanics, and complications. He is a long-standing member of the American Academy of Orthopedic Surgeons, the North American Spine Society, and has been recognized as a New Jersey top doc for more than a decade. Dr. Steve Paragioudakis, MBA, is a board-certified orthopedic spine surgeon with extensive clinical, academic, and leadership experience. He completed his medical degree at the University of Medicine and Dentistry of New Jersey and his orthopedic residency at New Jersey Medical School, followed by a combined spine fellowship at Stanford University and St. Mary's Hospital in San Francisco. He also holds an executive MBA from the University of Tennessee. Dr. Paragioudakis has served as orthopedic residency program director at Monmouth Medical Center since 2000 and previously held academic and clinical faculty roles at Stanford University. His career includes leadership in spine surgery education, functional restoration, and complex spinal disorders. An award-winning researcher, he is a recipient of the International Volvo Award for low back pain research and has authored numerous peer-reviewed publications and national presentations. Dr. Paragioudakis is an active member of the leading professional societies, including the American Academy of Orthopedic Surgeons, the North American Spine Society, and remains committed to advancing spine care through clinical excellence, education, and research. And with this, I'll turn this over to these two doctors to begin, Dr. Menkowitz and Dr. Paragioudakis. And I apologize if I got any of those names incorrectly said. So it's all yours now.
Thank you very much. We appreciate the opportunity. I'm Steve Paragioudakis, my partner, Dr. Menkowitz. Our practice is the Center for the Functional Restoration of the Spine. We have a junior partner, Dr. Dejanic, who's recently joined us. Our nurse practitioner is Courtney Brennan. And soon we will have a fourth surgeon, Dr. Dan Carrigan, joining us around September. As you can see on the slide, we, as a team, we are committed to providing excellence in spine care. This is us. The objectives of today's talk, and I thank you for your time, is go over some lumbar spine anatomy, review some common conditions of low back pain, review surgical treatment and non-operative treatment, provide some examples, and then we're going to lead into a discussion by Dr. Menkowitz about robotic spine surgery, which we currently incorporate in our practice and are one of the national leaders in performing these procedures. So just to review, this is lumbar spine anatomy. Of course, the lumbar spine is made out of 5 lumbar vertebrae, intervening discs. So for example, this is L1, L2, L3, L4, and L5. And down here, you would have the sacrum, which is the distal part of the spine. In between, the discs are named according to which 2 vertebrae they lie between. So this is the L1-2 disc, L2, 3, 3, 4, 4, 5. At each level, there's a neuroforamen. This is where the nerves escape the spine. And much like a map, go down and innervate specific myotomes and distribution of muscles in the lower extremities. Here's an overall view of the spine. The rectangular area is the one that we're currently concentrating on. Of course, you have the cervical, thoracic, lumbar, and then the sacrum. Lordosis is something that we always strive to maintain. This has caught a lot of attention in the last 5 to 6 years in spine surgery, especially with terms that you might have come across called flat back deformity. This is occurred, it can occur naturally, but with respect to spine surgery, in the past, fusions were created, and actually the fusion created a flat back deformity, which then led to adjacent level problems above or below, the fusion. So now this is gained. We strive and our goal is to restore this lumbar curve as best as possible. In terms of bony anatomy, this is an axial cut of a vertebra. This is where the disc would lie. Okay, this is the vertebral body. And then you may have heard the term pedicle screws. This is the pedicle bone. It's called the pedicle screws because the screw will actually go through this transpedicular path into the vertebral body. You have facets. You see here, there's one half of a facet joint on either side. You have the lamina. You heard the term laminectomy. This is kind of like the roof of the spinal canal. I often, in lay people's terms and explain it to patients, the lamina is kind of like the roof on an attic of a house. So you have the attic in here, you have the lamina, which is the roof on top. And when we perform laminectomies, it's kind of like taking the roof off of a congested attic to allow the contents to breathe again. Transverse and spinous processes, these are the transverse processes. Most of the muscles in the back will attach to the spinous processes and also to the transverse process. When individual muscles pull on these structures, they allow for rotation, flexion, extension, etc. Here's a posterior view. Now, this is putting two vertebrae together to call what we call name a segment, which is of two vertebrae and an intervening disc. And once again, here's the lamina. Here's the facet joints. Here's a full joint. And you can see that the facet joint is made up of an articular process from the vertebral body above, and also an articular process from vertebral body below, thus creating the joint. See the disc here from the back view. Now this here is a CT myelogram cut. This is an axial cut. We kind of see all those structures in play. Here's the vertebral body. Here's the facet joints. Here's the contents of the spinal canal, which is the dura. This is filled with contrast. And then these little dots inside the contrast are all the nerve roots swimming around in the cerebral spinal fluid. And these are, of course, facet joints. Here's a normal facet joint on this side. Here's an example of an arthritic facet joint on this side. And you can see some pathology taking place here. This is a normal joint again. There's very little obstruction here. But notice here what time is done. The facet joint has overgrown and is now beginning to encroach in the spinal canal here, which, as the condition progresses, will cause impingement on the nerve structure. Here's what about the disc itself? Here's the disc. The disc is very often compared to a jelly donut, right? Here's the outer crust of the donut. Here's the inner jelly, which should be very well contained. The inner jelly is called the nucleus pulposus. The outer crust of the donut or the hard shell is called the annulus fibrosus. Should be completely intact to contain this material in here, because on the other side of this, up in here, is where the nerve roots are. And this material, the nucleus, once it leaks out, is actually neurotoxic to those nerves and create pain and inflammation, etc. Besides a space-occupying lesion where a big fragment comes out and compresses on the nerve, the leaking of the material itself, if this outer crust is cracked, most often named an annular tear, will cause pain by an inflammatory response. Annulus, nucleus. Okay, so when we put two together, as I mentioned before, here you have a segment. Now we're adding the nerves in, vertebral body above, vertebral body below, the facet joint. You're seeing the disc here. Here's the exiting nerve root. Here's the dura coming out the side. Here's an example of a herniated disc, as I was discussing earlier. Here's where you have a tear in the annulus. A portion of the disc material has leaked out, and the red inflammation along the nerve points out to the pinched nerve, or the inflammatory response and the swelling being caused in the nerve and thus pain. Okay, so low back pain radiculopathy. As spine professionals, we're all familiar with this. It's the leading cause of disability in the US and worldwide. 80% of adults are affected in some fashion. Estimated cost $100 billion and rising in direct and indirect costs. After upper respiratory infections, the second most common reason for missed work days. Chronic symptoms will develop in 20% of those affected. And risk factors include poor posture, a sedentary lifestyle, heavy lifting, obesity, stress, occupations such as heavy machine operators, people that are exposed to high vibration frequencies during the workday will also cause disc degeneration. Common conditions, we're all familiar with disc herniation. We'll go over what spondylolysis means, which is actually like a small fracture in one of the bones in the spine. A spondylolisthesis, again, spondylo for the vertebra. A listhesis is the Greek term for a slip. Not a slip disc, but we actually have a slip on one vertebra on top of the other. And of course, what we all get with time is lumbar degenerative disc disease, whether it's predicated by an injury or whether it's just long-standing exposure. At some point, we all will develop degenerative disc disease. And the interesting thing about degenerative disc disease, it begins to develop from the time we begin sitting upright as infants. At that time, as the discs begin to load and you begin to sit upright, the discs begin feeling the pressure and the process begins then. Patient assessment, you have a patient with an injured low back with low back pain. 90% of the diagnosis will come with a thorough history. How did the pain occur? How long it's been there? What are the aggravating factors? What are the relieving factors? Do you have leg pain? Do you have back pain? What's a scale of it, 8 to 10? So the more thorough the history, the physician or examiner really will develop the diagnosis without even before the examination, and sometimes even before any diagnostic studies. In fact, diagnostic studies should be obtained to confirm the working diagnosis that's in place. So we start with a thorough history, then you do your examination, you develop the diagnosis, then confirm it with imaging, and you decide what kind of treatment is going to be best, non-operative or operative. And for the most part, and what I mean most part, greater than 90% of cases, 93% of cases, they're treated successfully non-operatively. Here's more examples of herniated disc, the axial load, the disc fragment coming out the back. There's different types of disc herniations. We often hear the term disc bulge, which is the most common, causes mostly low back pain. Then you have a disc herniation. The difference here is, imagine a disc bulge being when you let air out of a tire and it circumferentially bulges around the rim. It's uniform bulging around the rim. That's a bulge. A disc herniation is kind of like having an inner tube where there's a bubble on the inner tube, and there's a focal piece sticking out, pressing on a structure. The location of the herniated disc will cause various symptoms. It causes radiculopathy, which is the medical term for sciatica, or it can cause radiculopathy and low back pain. Again, important to differentiate because the treatment is often different depending on the percentages that of each pathology. So listhesis, I mentioned the difference between listhesis and lysis earlier. Spondylolisthesis is when you have an anterior slip of one vertebra over the other. In other words, one vertebra, like for example here, L5, has slipped forward over S1, and it's due to a crack in the pars bone. And this is what this represents, okay? Spondylolysis is when you can actually see the crack in the pars bone here, okay? And there's a difference. This is at L5S1. And at L5S1, the most common reason is this pars lysis. Then you have L4-5 slip, which is mostly degenerative in nature, okay? Degenerative disc disease counts for approximately 20, the disc counts for approximately 20-30% of the disc height of the spine. As we age, you can see how it's nice and tall here, nice and tall here. As we age, it loses its water content, begins to degenerate, becomes bone on bone. Your body's response is to try and fuse this on its own, but it never really achieves that. The problem with this is the neuroforamen, where the nerves are contained. When the disc height is well maintained, there's room for the nerve to exit. As the disc degenerates further, it encroaches on the neuroforamen, and these nerves begin to get squeezed with specific activities such as standing upright, rotating side to side, etc. Here's an example of an MRI. You can see here where these discs are nice and healthy. This is what we call a T2 image on the MRI, where water, anything that contains water, will appear bright. So these discs that are well hydrated will appear bright on the MRI. In discs that have begun the degenerative process, the water disappears. They become desiccated. Can you see they become gray, as you can see here at 4-5. And L5S1, which is a little further advanced, they become very dark. And then they also begin to bulge or herniate out the back. Okay, so common treatments of lumbar spine conditions, operative treatments are decompression. We perform a laminectomy, a microdiscectomy, a laminotomy, or foraminotomy. These procedures are basically intended to remove a certain portion of the bone or the disc or the facet to relieve pressure on the nerve and relieve leg symptoms primarily. They're not successful for relief of back pain. When you're addressing both leg pain and back pain, you often have to have a decompression, one of these, and adding a fusion, okay? So non-operative treatment, most common, as we're all familiar, bed rest no more than 2 to 3 days. You use anti-inflammatories either over the counter or prescription. You can use analgesics for acute exacerbations or more severe pain, such as low-dose opioids. Antidepressants are effective for radicular pain. You can fit the patient with a brace if necessary. You recommend an appropriate diet, exercise with respect to stabilizing and strengthening your core. And the second wave of treatment is interventional pain management. So this is the way I often describe it to patients again. Say, look, you have a herniated disc and you have sciatica. We can either go with this treatment, no injections. It's kind of like getting on your local road to get from point A to point B. If you add an epidural or interventional pain management, it's kind of like jumping on the expressway to get from point A to point B. So the decision is really yours, but most of the time, as is human nature, most people will opt for everything besides the injection as a first wave of treatment. And of course, if all of this fails in those 5 to 6, 7% of cases, then we entertain operative intervention and recommend it. If the patient's symptoms correlate with the physical examination, and then the diagnostic studies determine that, yep, that they had further evidence that that's the cause of the discomfort. Operative management. For low back pain, the standard approach has been a fusion. Historically, the results have been inconsistent, and we'll go over why that is. It's only offered after non-operative methods have been exhausted. Typically, the quoted numbers, if a patient is experiencing greater than 6 out of 10 daily low back pain for 6 months or longer, and we have not been able to break the cycle either with non-operative treatment or interventional pain management, and they still continue to have these symptoms, then we start entertaining fusion surgery. Besides fusion, total disc replacements are an option, but if you looked at the strict criteria for total disc replacement in lumbar spine, those patients are less than 1% of cases walking into your office that are true candidates for total disc replacement. We do disc replacement. We adhere to those strict guidelines, and our success rate has been very, very good, over the long term. Fusions. Traditionally, fusions were performed without any instrumentation. They would perform what's called an in situ non-instrumented fusion, meaning no screws, where they would take bone from the iliac crest, as you can see here. They would make it into chips. They would decorticate those transverse processes in those facet joints that I showed you earlier, and they would lay the bone chips down along the fusion bed. Over time, and they would brace the patient, and over time that would glue together and provide a fusion. And when you look at the literature, the overall success, the fusion rate was 72%. The clinical success was even less than that. So that prompted, spine surgeons to say, well, how can we make this better? Okay. So this is an example of a patient dating back to 2004 with a non-instrumented fusion. You notice this big black area here. This is a laminectomy. You can see the bone's missing. So decompression was performed. And then that bone that was removed from here was cut into chips and laid along the sides here, and they performed a non-instrumented fusion. Okay, it went on to what we call a pseudoarthrosis, meaning it was in a 28% where the fusion didn't take and the patient had continued symptoms and probably required further surgery at that time. Then you say, well, why can we make these better? Then this was the addition of the pedicle screws. The pedicle screws were inserted in a transpedicular fashion after the fusion was completed. This added further stability. These are screws tightened together by 2 rods and made that segment more stiff and stable, kind of like providing an internal cast. And that support led the fusion rate to jump up to 87%. Then 87% not good enough. How can we make that even better? Here's an example of an instrumented fusion, multi-level from L3, from L2 to S1, lots of bone along the sides, okay, pedicle screws. When you see this amount of bone, usually taken from the iliac crest, that in itself is caused a lot of pain post-operatively, period. This is the lateral view. So how can you make this better? A consideration were then given to using these interbody devices, okay? These are, when you remove the disc, you do the fusion just like we did before, but you remove the disc, you insert something in its place that's filled with bone, and doing that increased the fusion rate now to 91%. So you can see historically as time went on that these techniques became better and better and better. And here's another clinical example of that. Okay, so the evidence for lumbar interbody fusion, as you can see, 91% posterolateral fusion at 11 months, 60%. When you use the interbody, jumped up to 91%. Similar outcomes with other studies. Okay, the other advantages are we can restore the disc base height. As you can see, we put those cages in place of the disc, restore the height. We could correct that lordotic alignment that I mentioned earlier on in the talk. Prevents progression of subluxation in patients. In other words, you stabilize them so they fuse where you fix them. Provides load sharing, prolongs the life of posterior instrumentation. In other words, the hardware, because it's metal, if you don't have that interbody device, there's micromotion occurring there, which will often lead to broken screws or rods. We've been able to decrease that by putting the cages in the disc. And of course, the higher fusion rate, as we saw. The indications we went over before: listhesis, scoliosis, degenerative disc disease, spinal stenosis, pseudoarthrosis, failed back syndrome, post-laminectomy syndrome. These are all indications to perform those procedures. And here's various devices that have been developed over time to prevent that. This is an A-lift cage inserted through the front. These are no longer used. These are called array cages. This is a graft that was made out of allograft cadaver bone and machined with a center slot that you filled with the patient's host bone. These are also, they're around, but very few people use them. This is what we call, and these are all inserted anteriorly through the front of the abdomen. These are posterior devices, and these are called PLIF cages, where they can be made out of titanium, PEEK, or allograft. PEEK is a plastic that's utilized in orthopedic surgery that has the qualities of bone that can be used for screws, cages, etc. The techniques of the interbody fusion I mentioned before, in our practice, we use all of these. A-lift stands for anterior lumbar interbody fusion, where we come in through the front of the abdomen through small incisions. You have X-lift, where you come in through the side of the patient. What we call a transpsoas approach also has certain advantages. A PLIF is done through the back, posterior lumbar interbody fusion. Then you have a transforaminal lumbar interbody fusion. And then one of the techniques that we currently use and has provided tremendous success is called the MASS TLIF. We will describe that. This is a robotic-assisted procedure now. We're able to accomplish all the goals of those procedures: laminectomy, decompression, providing screws through two small incisions in the spine, which has led to tremendous advantages with respect to outcome and decreasing risk factors across the board, risk of surgery. So here's a MASS TLIF. So instead of a center incision where you would come down the middle and have to remove all this muscle off of the bone, which in itself will cause a tremendous amount of morbidity and pain, we now use this procedure called exposure called the Wiltse approach. The Wiltse approach has been around for 70, 80, 90 years in spine surgery, was regained popularity recently because we have these instruments that through this small incision and we work between the muscle bellies, we could get exposure down to the spine and leave all this soft tissue attached to the spine. And through those small incisions, we're able to perform a laminectomy, take away the disc, take away decompression, perform a facetectomy, take all this pressure off of the spine, insert screws, and insert the cage all through these sometimes 1-inch incisions through the back of the spine. The challenges and why this approach is not utilized too often is as a technical learning curve, about 25 to 50 cases until you become comfortable and experienced and are able to do all the things that you can with traditional open surgery. To get to this level takes a tremendous amount of dedication and exposure. The decompression, you wind up being limited at first because your view of the field is different. But as you gain experience, the amount of decompression you're able to achieve and perform closely mimics what you're able to perform with an open procedure. You're able to prepare the disc space. At first, it takes a little bit a longer operative time to get to know it. But because the incisions are smaller, it's just a longer anesthesia time. There's much less blood loss, much less morbidity, and much less use of opioids post-op. And we're able to use the robot, as I mentioned. The advantages: less blood loss from around 640 cc's average to about 150 cc's during procedure. Length of stay is decreased for approximately 3.2 to 1.7 days. This is in our practice. Opioid use has been decreased. Our experience has been 58% reduction in post-op opioids as documented by our anesthesia service in one of our hospitals. Return to functional activities faster. Post-op week 1, 75% are walking up to 1 mile, no assistive device. The majority of them are off of opioids by 7 to 10 days post-op. And with that, I'm going to turn it over to Dr. Menkowitz to discuss robotic surgery. But as you can see, incorporating these procedures, MASS TLIF with the robot, provides tremendous advantage. Thank you.
Hi, everybody. I get the fun job here. So these are all our new fancy tools that we've been, that has helped us change the way we practice and actually make it much safer and, more efficient, and as far as blood loss, opiate use, and stay in the hospital. So just to review what you see in this picture here, this is the actual robot. So we drape this off sterilely, and this is the robotic arm, which I'll discuss later. This is an intraoperative CAT scanner, and this is the screen and the eye of the robot. So the eye of the robot is going to go. It's a camera that's looking at arrays that we put into the pelvis of the patient, like antennas. So as long as this camera can see these arrays on the patient, it speaks to the robot over here, and it is all done by us getting this CAT scan at the beginning, so the robot knows where the patient is and everything about the patient. So to let you know, this is robotic assisted. This is not, and it's different than other robots you might have seen. This is not like the Da Vinci where the surgeon is off the field, not scrubbed in, with their head in a camera and hands working the robot remotely. This robot is more of a navigation system with guardrails. So we choose and we pre-plan how we want to put our cages and screws in prior to doing it, and the robot arm will target the way we do that. We do all the work through what we call the end effector, or the tube that's attached to the end of the robotic arm. But the robot itself does not do the surgery. The humans still do the surgery, but it's giving us protection. So with robotics, we're improving patient care, like I said, enhanced surgical experience, and we are driving efficiencies. So to understand, it's very versatile. It's becoming more and more every day. And we're, again, like Steve said, we're some of the leaders in robotics. We've been doing it for over 7 years. We've done close to 1,000, if not over 1,000 patients. And as far as putting screws in, we've done, probably upwards of 10,000 plus screws we've done. And it certainly has been, life-changing for both the patient and us. Obviously, there's a learning curve. It took, between 30 and 50 patients, I would say, to get us to be as efficient and then become more efficient than we were prior to using robotics, when we just did everything freehand. But the safety factor is tremendous. This is an example of what the robot arm does here, if I can get to play. So we pre-plan where we want the robot to go, and we step on a pedal. So that would be one screw. Now we're going to say we're going to do a screw on the other side, on the right side. Now we're going to go back to the left side. And this tube is the end effector. And that's where we work through with our instruments, our drills, and all our instruments we work through. And we're watching, not only are we working through there, it's live navigation on the screen. So we have the guardrails of the tube, so keeping us, in line of what we had pre-planned. And the navigation is making sure that we're doing what we had planned. These are the antennas we talked about. So this antenna that has these 4 balls on it is looking at that camera we said that's off the field. This antenna is looking at this antenna. So there's two safety things. So if this antenna moves, this one will indicate and the robot won't let us proceed. And if same thing, if this one moves, they talk to each other. And if this one is not being seen by the camera, it also will get a warning on the screen that we can't proceed. So there are a lot of guardrails and safety features built in. So this is what we're looking at, and I guess you guys are mostly up in Boston, so I'm sorry, I'm a Phillies fan, so we're not quite as good as the Red Sox, but we try. So this is what we're looking at. So I'm working through the end effector. Here's the wound here. Here's the robotic arm, and I'm watching the screen, which is live navigation of me putting these screws in. And this is one screen I look at. Our room is filled with multiple 75-inch TVs that it's all hooked up to. So we're really getting the visualization anywhere we possibly look. This is the way we did it prior, was stealth. So it's the idea of still looking at the screen, but now the surgeon is not working through the end effector or that tube. So, you have an idea where you're putting the screw in, but you can certainly move, even if you sneeze, cough, you twitch when you're putting it in, you can put the screw, off where you want it to be, because it doesn't have that tube as the guardrails. And this is the original way. This is what we call freehand technique. This is the way all, spine surgeons, my generation, and, certainly older, the super young guys may not have ever done this, but it's the idea we used to put screws in just purely by anatomy. So this like Dr. P said earlier, these are part of our articular process or transverse process. And in that, and our lamina comes up in here, and in that intersection, is where we targeted. And we wanted to stay, obviously, like everything else in this world, in the green and not in the red. The red would be breaching the canal. And when you breach the canal, you can grade your screw placement from 0 to 3, which is really bad, where the screw is in the canal. And you can see that idea in these CAT scans. And even within the best hands, when we did a freehand, there were certainly misses. And thank God, a lot of times there was no patient problem or neurologic deficit. But sometimes we would get CAT scans, or it wasn't even us. A general surgeon would get a CAT scan for looking for an appendectomy, and as they're scanning the cat, doing the CAT scan, it clearly shows one of our screws is not where it's supposed to be. And this is the fear we had when we did everything freehand. So now the whole idea is we're at decreased operative time. Now, like I said at the beginning, it was not. It was certainly longer to do these cases, but after about 50 cases, we got faster. Now we're actually significantly faster than we were prior. We're reducing radiation for ourselves and all the staff in the OR. The patient obviously does get radiation, but it's a one-off. The patient's not getting it every day, so it's not a dangerous amount of radiation. And honestly, even when we did the freehand, we had to bring in the C-arm all the time to take X-rays, and that gave it a lot of radiation. So, and obviously the improved accuracy is, the key here. These are very cool studies because this is showing how accurate this thing is. So specifically the study on the left-hand side is showing that with fellows doing this and experience versus an experienced spine surgeon, it's virtually the same accuracy. So you don't, obviously you can, we've learned being in a lab, you can really force this thing and you can put the screw in the wrong spot if you really don't look at it and watch the technology, or you go too fast and you're not careful. But if you're really doing everything in the steps that we have learned, the accuracy is, as close to 100% as possible, no matter if you're an experienced spine surgeon or not, which is amazing. And here again, it's showing the accuracy on another study. It's still 98.3%. They were, nothing is 100% in this world, but these are getting very close. And this is a comparison to all the ways I said before. So 98%, 98 to 99% for robotic compared to navigation, which is 95, to fluoro, which is live X-ray, is 90, and then freehand without anything was 85%. So doesn't seem like a lot, but if it's your back, your spine, your loved one, you want as close to 100% as possible, and this puts us in that realm. So this is an idea of what we're looking at when we're this is the navigation. So this is our drill. We're watching this on the screen as we're working through the tube. So we drill, the X is the tip of the drill. And now we're going to put the screw in. Here comes the screw. And as we advance it, on the right-hand part of the screen, you can see this is we're doing a left L3, and our goal is to get the check mark here. That means we're within it's a quarter of a millimeter of what we planned. So as long as we're in that realm, we're extremely safe. And now we got the check mark. Now we know we're in a good spot here. And again, this is a time lapse of obviously we're not this quick, but this is showing how we do it and doing all our techniques. This was over a wire. When we do a mass lift, we have to do it over a wire because the retractor won't fit through the end effector. So we do all the work and then we put a wire in and then we put it, we put the screw with the retractor over the wire, but we still can navigate the whole thing. So I'm going to show you some cases that shows why this is so great. So we've always done complicated revision surgeries, but the risk was always there, and it's still obviously still there. But we're able to undertake things that are much more difficult than we could in the past because of the robot. Here's an example of a patient that had bilateral sacroiliac fusions done at an outside institution by an outside surgeon. Patient actually had significant spine pathology, and that's probably why these SI fusions did not work. So in order to connect this to a new surgery we do, we're going to have to figure out how to get a screw in between these bolts that are in the pelvis. And doing that freehand or even with C-arm, it can be done, but it'd be very difficult. And if you have to go in and out with the drill multiple times and you can't get it, it just does significant damage to the pelvis. So we were able to sneak these screws in between these other bolts which, worked out, great for this patient. And we were able to do this with a pretty significant, significantly quicker than we could otherwise. And the blood loss was very minimal. Here's another example. So this is another surgery. As you can see, we do a lot of revision surgery. So this was done by another doctor as well, and he did a different kind of spine technique. It's like an inside out technique, so not typical pedicle screw technique. So pathology for this patient was above. We really didn't want to take out this hardware. So our goal was if we can get in these pedicles, which are underneath these screws, connect there, we can able to put new hardware in minimally invasive without actually disrupting any of this. And we were able to do that. So we were able to get these screws underneath these other screws and then connect a whole new construct above. This is a patient that was sent to us as a revision where the patient actually had this TLIF for this cage placed and they fused too much. So what had happened is this bone, which inside the cage, started growing into the neuroforamen right here. And this is the bone right here. And you can see it here on this CAT scan. The bone grew into the neuroforamen where the nerve comes out. So we were able to go in with the end effector, target that piece of bone, use a drill to drill out that bone, and then give the patient a new construct, which is here. Here's a cool case. So this patient had actually by one of my mentors did this about 45 years ago in New York City, had this stainless steel construct, and with a significant flat back, we needed to address the levels above, and it had been, it was very scoliotic, very old hardware. Removing this hardware would have been very, very difficult. So we were able to use navigation to put these three cages in, all minimally invasive, around this old hardware that we didn't have to touch, and which would have been, again, extremely difficult without the robot. Here's another case. So there was an old trauma case. A woman was involved in a motor vehicle accident, had significant spine pathology above. You can see the spinal listhesis here, but they connect screws in with these pelvic bolts that were there from a previous trauma. Would have been extremely difficult. But now again with this, we were able to sneak these in around those two massive screws, and we were able to do the spine surgery we wanted to do without disrupting this trauma construct. And this is an example of probably the most we ever did. Now, this was not done in one sitting. This patient had multiple operations, first her lumbar, and then her cervical, and then her thoracic broke down. But we were able to put all these screws in safely using the robot and connecting all the constructs together. And this patient, amazingly, has done very, very well. And this is again, this is the example of that a pars fracture. And here's the pars fracture here. And we were the first in the country to be able to use the robot to fix this pars fracture minimally invasive. And this is typically an injury that most surgeons don't undertake because the success rate was very poor with the old techniques we had. So we were
that typically would have been a lumbar fusion. And this specific patient was a guy is a gentleman in his 30s who owns he was a contractor, and he's been out of work because of this fracture, had pain management, physical therapy not getting better, multiple surgeons, they recommended a fusion, young family, recently married, had his own business. And so he came to us for a second opinion. And again, using this technology, we're able to perform the following.
Right. So you can see up here that this is the fracture where we guided, and we were able to get a guide wire across the fracture. And then with the guide wire in here that you're showing, we're putting this drill across the fracture. We're going to follow it by a guide wire, and we're able to put a compression screw across to compress this fracture, and then able to bone graft on top of that, which was in here's the screw, and this is when it had healed, which is amazing that we were able to do that. And here's the CAT scan to prove it healed. So that fracture line that was across is no longer there. And now this person has full range of motion, wasn't fused, and it can go back to all normal activities, and we're able to accomplish that all through very, very tiny incisions.
Yeah, so now he owns an excavating company. He's got 15 employees. He's got 4 kids. We see him back. This is like post-op year 4 or 5 on him. Extremely happy. So as you can see, so this would have been like one of our like typical workers' comp cases, with a fusion. maybe some chronic pain, etc. Yet he was a candidate to do this. Not a typical, answer from a textbook, but something that where the patient's pathology fit the technology that we currently have, and we're able to provide an alternate treatment option.
And this is where it's going. So, again, like I said, we're at the tip of all the technology. Globus Medical is the one we use, typically the current robot, and they always invite us out their lab. So this is Google Glasses, what's the next step. And so all the things we saw on the screen, including the CAT scans and MRIs, are all going to be in these glasses. It's a little overwhelming, but we're gonna have to get used to all the information, but it's pretty tremendous where we're going. Now this is our team here. This was after our 200th. We got to update. Like I said, we're over 1,000 now. And that's it for our presentation. And we would love to take questions.
Before you take questions, can I say that's absolutely fascinating. This is the first time I've seen this and in such detail. So I really appreciate you presenting that. That's amazing. And now I'll be quiet.
So I will stop. I guess I'll stop sharing. Yeah, okay.
Yep, no problem. Thank you, guys. So thank you, Dr. Menkowitz and Dr. Paragioudakis, for sharing all of that information and insight about the evolution of spine surgery. At this time, we will shift into our questions and answers, and I do have a few for you. And please be sure to submit your questions using the Q&A feature within the Zoom dashboard. If you're seeking a CEU credit along with your certificate of completion from today's webinar, please take a moment to complete the form on the screen using the QR code. In the meantime, let's shift over to our questions. I've got a couple for you guys. So with the robotic process, does it do neuromonitoring as well? And if it does not, does that still occur?
It currently doesn't, but we use neuromonitoring that it works in conjunction. It's not the robot itself. I know that is a next generation they're talking about, but our normal neuromonitoring can hook onto the robot and you hook onto the screws just like typical, and we monitor all our screw placement and everything else.
Yeah.
Yeah, great. And what is your rule regarding patients with, bear with me on this one, spondylolisthesis with flexion and movement? When is surgery recommended and how urgently does it need to be done?
So as I mentioned earlier, there's two types of spondylolisthesis. There's the degenerative spondylolisthesis, which most commonly occurs at L4-5. And this is a gradual developing process, most commonly seen by the time the individual becomes symptomatic. They'll present what we call neurogenic claudication and back pain. Typically occurs in older individuals because it is a chronic degenerative process. And then there's the isthmic spondylolisthesis, which most commonly occurs at L5-S1. And that process begins when patients are basically in their teens. The bone that connects that pars bone doesn't completely ossify, doesn't completely become bone. It's kind of like cartilage. And as long as that disc between L5 and S1 remains healthy, patients will have occasional back pain, but they won't seek like medical care for it. So as they get a little bit older and that disc begins to deteriorate a little bit, or they get a herniation, and all of a sudden they have sciatica and back pain, they come to the orthopedist's office, they get x-rays, and you've had an L5-S1, isthmic spondylolisthesis for quite some time. The perfect example that I can provide for you is I treated a defensive lineman from the University of Iowa many years ago. 6'4", about 270, played in a Rose Bowl, played high school football, college football, wasn't a pro player, but he played all those years, the heavy lifting, defensive lineman, high energy game, never had a problem with his back. Graduates from college, is hanging out down the shore here at the Jersey Shore, does some type of like funny twisting maneuver, all of a sudden excruciating back pain. He comes to my office. He had a chronic spondylolisthesis at L5-S1 for all those years. He ultimately wound up having a fusion because his pain wasn't getting better. So to answer your question, it's not an emergent operation. It's not an urgent operation. It really depends on the constellation of the intensity of the symptoms, how long they've been there, and what the patient has gone through.
Wow, interesting. Okay. And what are the restrictions against spine fusion? Is there a weight limit to that? And what's your recommendation regarding stopping or quitting smoking along with that?
All right, so I'll answer the second one first. The smoking, obviously smoking makes this a much more difficult thing for the patients as far as your rate of fusion. It's about half when you're a smoker. Your skin healing, soft tissue healing, all that. Because smoking, besides all the medical problems with your lungs and all your organs, it also constricts your blood vessels, and we need blood to heal broken bones, and that's what a fusion is we're creating, setting your body up to heal a broken bone. So we need the blood flow to go there. So smoking is, certainly it makes this much harder on the patient. There's things we have, BMP and things like that that help, but we really caution our patients to stop smoking. And unfortunately, that includes nicotine gum and patches and everything else because it all affects it. It's the nicotine is the big problem. So we really try to, keep them, try to get them not to smoke. Now, as far as weight limit, of course, right? Obese patients, again, the complication rate is significantly higher. I mean, and we're depending on how obese we're talking, there is a weight limit for our tables as well. So, and your spine is set to hold a certain amount of weight. If every pound you put more on the spine, it's putting more stress on your back, and which would make the surgery not as successful, and you're just not feeling as well. So we do caution patients to try to lose weight, and now we do have these great weight loss drugs that are out there that we certainly will recommend to patients who we feel are candidates for that, as long as their primary care doctors are on board with it. And we try to get them to get as skinny as possible. And we get the fact that the double-edged sword. If your back is killing you, you can't exercise, which makes you gain weight, and it's this horrible cycle. But with the medicines and counseling, we hopefully can help break that cycle.
So here's the ironic part with obesity and spine surgery, and there's definitely contraindications in the traditional literature, but using the robotic approach in an emergent situation where you have a morbidly obese patient with severe stenosis, they have a foot drop, etc., that something needs to be done, we can actually use the robot and tubes. So using even that small incision, we have the instruments that are long enough and deep enough to at least provide a decompression and save neurologic function without needing to do a wide exposure that's going to be 6 inches deep. It's going to be 1,500 cc's of blood loss that traditionally would have all those risk factors. Sometimes the robotic approach in those obese patients is a better option than the traditional approach. So that's the other advantage of this new technology.
Fascinating. Great. And the last one, how often do you see the entire spine done?
Oh, like